معناته والله السي ار هو اللي يوصل الحضور والغياب للسكرتارية، لأنه البرنامج اللي نازل للحضور والغياب للإيه.
خلاص تمام، أنا بخبرهم إن شاء الله.
طيب هلا الحضور 22. طيب لأنه في ضيق في الوقت يمكن ما نقدر نستنى أكثر من هيك. بسم الله الرحمن الرحيم. أول شيء أنا إلي عتب عليكم الصحيح اللي التأخر في الإخبار. يعني أنا امبارح بعثت للسكرتير على الساعة 9:30 بالليل، إنه لغاية الآن ما صار أي تواصل. اضطريت إني ألتزم بعملية يعني. طبعا هذا عدا عن الانكونفينينس في التايمينج اللي هو التحضير. يعني ما في مجموعة سابقة لا رابعة ولا سادسة طلبت عن الستومز. أنا بحب لما أحضر يكون التحضير عبارة عن صور وفيديوز ومجال للنقاش. فكل اللي راح تشوفوه حاليا تم تحضيره خلال الساعة الماضية فقط، وبالتالي بجوز الترتيب ما يكون بالطريقة اللي أنا بدي إياها. يعني أنا متأكد أنه بقدر أرتب أحسن من هيك، بس هذا نتيجة التأخير. هيك الصورة واضحة، السكرين واضحة.
دكتور مش طالع عنده شيء
ولا شيء. ها هيك طلع.
دكتور.
واضح.
طيب فبرجع بكرر الترتيب مش زي ما أنا بدي. فأنا كنت يعني أحاول أجمع سلايدز وتو جروب ذم توجذر حسب المواضيع، فراح يصير في نوع من التداخل. So what's a stoma؟ خلينا نشوف في حد بيقدر يجاوبني what's a stoma؟
دكتور it's an opening بتكون من ال abdomen through the skin أو
وستوما باللاتيني هي عبارة عن فتحة، مش الماوث ستوما، مش بيحكوا ستوماتايتس مثلا. لما بنفتح إشي في البول مش بنقول استومي، استومي. فهي فتحة. عادة احنا لما بنحكي على الستومز يعني كموضوع للدسكشن بنحكي على الانتستينال ستومز in which we deliver the small or large bowel to the through the abdominal wall. So the opening of the small or large bowel will be outside the abdominal wall, opening in the abdominal wall. طبعا you can have it in the stomach, gastrostomy, or jejunum, jejunostomy. You can have it in the ureter, ureterostomy. بس عادة لما احنا بنحكي intestinal stoma المقصود فيها the small intestine or large intestine. So it's what you see here. This is an opening in the abdominal wall and you can see the bowel outside the abdominal wall. So the stool will be coming through that opening. And the content of the stool will depend on what sort of bowel is delivered outside. فأنتوا إذا بتتخيلوا الفسيولوجي of the GIT how the intestinal contents are poured in the intestine along with the food, and how the absorption is taking place, and how the content is becoming thicker and thicker. And we leave the small intestine with around 3 liters of contents, and then the journey through the colon, through which we will have absorption of the contents till we end up with something like 150 cc of stool. So what is coming out of the stoma? You can imagine it. Where is that opening? And what sort of contents do we have at that level? Of course, there are personal variations because the bowel habit and the stool contents vary from one person to the other. So that is what we mean by stoma. And how do we collect the stool? We collect it in a bag like this. رح نعطيكم التفاصيل يعني هلا بمرور الوقت. So instead of going to the toilet, the contents will be poured into this bag. Again. So there are two systems for this collection. One of them, it is a 1 unit collection. So as you see, the bag and the base is 1 unit, and it sticks on the skin. And we have another unit in which there is a base which is isolated from the bag. Some of them are closed like this, so you can throw them because these are disposable. Some of them are having a draining system so that you can open it up and pour the contents in the sink immediately. So this is the two pack system. There is a separate base, which what you see here, and there is a bag that is fitting on it. The base can stay as long as it is there, but the bag will be changed according to the outflow. So remember, we have 1 unit, sticks directly on the skin. Some of them are closed, some of them are open, some of them are two pieces, base and bag. So when you hear the term base and bag, this is what we mean by base and bag. So this is the closed system. Of course, there are so many components, so you will see different shapes, and there are so many innovations regarding how to decrease the smell, how to decrease the volume, etc. So this is the closed system, and this is the drainable system. And there are so many fitting devices that are used by some in order to fix it more, to avoid its dislodgement and some accidents, etc. Again, you will find so many devices to help in this regard, although I see that most of the patients, they do not use these. They are happy with it as it is. And some people use their own fixing systems, which is the simple plaster. Of course, this is the base. The bag is not there in this patient. Again, so many companies. There are so many sizes, and many of these you can decide about the size. So you open the opening in the bag that correlates to the size of the stoma. The site of the stoma should be identified before surgery by a specialized nurse while the patient is standing, while the patient is putting on the clothes that he likes, in order to choose the best place for the stoma. However, we should make sure that when the stoma is put, whether 1 piece or 2 pieces, it should be away from bony prominences like the iliac crest and the symphysis, away from scars, away from the umbilicus. So the bony prominences include the costal margin, the iliac crest, the symphysis, then the umbilicus, then any scar according to what you are planning. So the best places are in the quadrants: left lower quadrant, right lower quadrant, right upper and left upper. The most common sites are the left lower quadrants for the colostomy and the right lower quadrant for the ileostomy. When we construct the stoma, we try to make it as distal in the bowel as the condition permits in order to provide the patient with the maximum absorption of the contents. So if you are obliged to do it in the small intestine, if you can do it in the terminal ileum, do it. If you are doing a colostomy, if you can do it in the sigmoid colon, do it. That's why these are the two most common sites. We have a 2 minutes video about the caring of the stoma. نشوف كيف بدي أدخل عليه. وين الشيرنج؟ المفروض يكون في شيرنج. معلش يتحملوني شوي إذا قدرت أوصل ل اللي بدي إياه.
مش مشكلة يا دكتور، خذ وقتك.
والله ما أنا عارف، هلا حكولي كيف. لا والله شكله بدي. خلاص بلاش، إذا ظل وقت في الأخير برجع له. رجعوا السلايدز هيك؟
دكتور.
دكتور.
إذا السؤال: why do we need to do a stoma? I don't think anybody wants to have a stoma. لو سألنا حالنا سؤال، أنا بحاول أحكي شوي شوي لأنه أنا متأكد أنكم تعبانين آخر النهار وكذلك أنا. لو سألنا حالنا سؤال: if somebody is having a pathology in the bowel, whatever the pathology, and we ask that person, and this pathology needs surgery, and we ask that person, what is the best thing that you like to have? يعني تمنى. The answer will be, I want the pathology to be resected. I want the two ends of the bowel to be hooked together, which is the anastomosis in the medical language. I want this to be done in one operation, and I want to keep the continence. حد بيقدر يعني يفكر بشيء ثاني بتمناه المريض لما بدنا نحكي له إنه في عندك باثولوجي في البول and you need surgery to remove the pathology, to re-anastomose the ends, to do this in one operation, and to keep the continence. So in brief, the stoma is done when you cannot achieve any of these. You cannot resect, so you want to a proximal stoma to divert the stool away from the pathology. You can resect but you cannot anastomose. معناته the proximal end should come as a stoma. You cannot do that in one operation, either because the circumstances of the surgery does not allow that. The field is so messy. راح نحكي بعض التفاصيل بعدين بس احنا مشان الاختصار. Or you anastomose but you are afraid that the anastomosis will disrupt. So you do a colostomy proximal to the anastomosis, waiting for the anastomosis to heal. And in some patients, the pathology and the operation includes getting rid of the continence mechanism. فاهمين هاي السلايد؟
دكتور.
بهمني جدا يكون في إجماع على فهمها لأنه يعني عمليا this is the lecture. So the ideal thing is to resect the pathology, to anastomose the two ends, to do this in one operation and to keep the continence. If we cannot do any of these, we do a stoma. We cannot resect, you cannot anastomose, or you anastomose, but you want to protect it, or the anastomosis is done in another operation, or the procedure includes removing the continence mechanism. Now, what sort of stoma I will do will depend on what is the pathology, where is the pathology, what is the operation I'm going to do, and what are the circumstances of the operation. إن شاء الله تتوضح الأمور as we go through. إذن نكرر. When you cannot resect, when you resect but you cannot anastomose, or you need more than one operation, or you need to protect the anastomosis, or there is loss of the continence. So what stoma you are going to do, depending on what we have mentioned, what is the pathology, where is the pathology, what is the operation, what are the circumstances, you will decide what you are going to do. So your options are a colostomy versus ileostomy, an end versus loop, we'll explain this, and is it a temporary or permanent? So actually, if you want to describe any stoma, these are the points that you are going to describe in addition to the site of it. So you will say that this is, for example, a loop colostomy or a permanent loop colostomy in the left lower quadrant. This is a temporary end ileostomy in the left lower quadrant. So these are the variables that we play with when we decide about the stoma and if you are going to decide to describe the stoma. Is it a colostomy or ileostomy? Is it an end or loop? Is it temporary or permanent? And where it is located. This diagram shows what do we mean by end and loop. So the end, there is complete cut of the bowel, and this end is delivered as an end stoma. The loop, as you see, one loop of the bowel is delivered and an opening is done in it. This can be done in a colon or a small intestine. And you can do this permanently. The patient will not have it reversed, or temporary if the patient is going to have it reversed. So this is how what you are going to describe the stoma. Colostomy or ileostomy, end or loop, temporary or permanent, and where it is located. Of course, I can't show you photos till tomorrow because I photo all the stomas of my patients at the time of reversal at least, but I'll show you some. This is an example of a loop aliostomy in the right lower quadrant, a temporary one. طبعا you cannot say temporary from what you see. I'm telling you that because I know the circumstances. Why it is loop? Because it is having two openings. This is one and this is one. And this is the intact posterior wall in between. Now you will ask why they are not similar. Because we deliver the proximal one more to the outside because this is the one that is going to pour the contents. So we like to have it something like 2-3 centimeters above the skin so that the contents will not pour on the skin, they will pour in the bag. So this is a loop, aliostomy, in the right lower quadrant, a temporary one. Again, I think the same patient in another review.
دكتور عندي سؤال بس او بخصوص هاي كمان او اللي قبلها، هاي صاير لها برولابس؟
لا، ما قلنا احنا we deliver it outside 2 to 3 centimeters so that the contents will pour in the bag. It will not pour on the skin. تعرف كيف الإبريق في له فم؟
فهمت
زي
عليك.
شوف انت اذا بدك مثلا تصب من كاسة كيف الكونتنتس بيطلعوا، صب بشيء له زي الإبريق you can control it.
صحيح.
Again, this is definitely an allostomy because you see the valvuli conventus of the small intestine. هذا أي واحد بتطلع عليه بيعرف إنه small intestine، زي الآلة الموسيقية هاي اللي بتفتح وبتسكر هيك، بعرف شو بسموها، زي الأكورديون. طب ليش لوب؟ إحنا شايفين وحدة، لا في هنا opening، أنا بحكي لكم في هنا opening، بس هذه هي البروكسيمال اللي بتطلع، إحنا عملناها لبرا أكثر، و it is under continuous function. هاي it is collapsed, it is not functioning لأنه ما بيطلع منها إلا a little bit of mucus. And this is nicely created stoma because as you see there is no skin reaction whatsoever. اللي انت شايفينه هنا محل تلزيقة البيز هذا عبارة عن ستول. هلا بس أورجيكم صورة السكين when it is eaten بتعرفوا شو المقصود. Again هلا هذا it is delivered، يعني خلينا نحكي على الماكسيمم، أكثر من هيك بجوز نصير نسميه prolapse. هاي عندنا الأوبننج، شايفين كيف بيطلع منها الستول، وهاي الأوبننج الثانية. هذا اللي هون اللي هو البوستيريور وول اللي ما فتحناه من الوول، لأنه لما بنفتح الوول بنفتحه زي ما نحكي مثلا 2/3 بضل البوستيريور وول انتاكت. شايفين سكين كيف completely healthy لأنه هذا فيه له لينث لبرا. It's very healthy skin. يعني أنت تتمنى لو كل ستومز السكين فيها بكون بالطريقة هاي. Again, another one, you can see the valvuli conventus or rugi of the small intestine. You can see the other opening and look at this nice skin. The surgeon is proud of creating this stoma. Again, the valvuli conventus are clearly shown. Here we have some reaction in the skin as you see, but basically بشكل عام it's an excellent skin. Again هلا I cannot say that this is an end or loop because it is covered here. So I can say that this is a small intestine, but I cannot judge whether this is a loop or end.
دكتور
This
هاي مش
is
مبين انه كثير
sorry.
كثير طلع برا؟
نعم.
مش كأنه هاي كثير مبين انه طلع برا اكثر من اللي قبل؟
لا يعني it depends على هلا بجوز يعني البعض يقول لك والله يعني لو اقل شويه احسن. انا personally I like it this way لانه this protects the skin more. هلا راح اورجيكم البرولابس you will see what do mean by it. This is an end colostomy. تلاحظوا اول اشي it is an end فتحه واحده. colostomy ما في الروجي تبعات السكن. عادة الكولوستومي بنطلعهاش زي الاليوستومي لأنه الكونتنتس اللي بتطلع منها مور سوليد. كلاسيكالي ممكن تقرأوا في الكتب إنه الكولوستومي بنعملها even with the skin. Personally I don't like that. I deliver it a little bit outward لأنه حتى الستول ممكن يكون شوي فلويدي يعني ليس بالضرورة إنه الستول يكون صلب. So it is this and you look at the skin again. هذا اللي انتم شايفينه هذا الايودين at the time of surgery. So this is an end colostomy. Nicely created. Look at this one. This is a loop. If I'm not mistaken, ileostomy. There are two lumens and nice skin. طبعا some people develop some reaction to the base itself يعني نفس مادة البيز اللي هي اللي زي البلاستيك أو كذا يعني ممكن يصير reaction. Again this is a loop. You can see this opening اللي هي البروكسيمال اللي بيطلع الستول و this is the distal and this is the posterior wall in between. This is a closer view. هذا posterior wall اللي هو intact. This is the proximal. This is the distal with a little bit of reaction negligible يعني. هذا نفسه بس غيرنا الاتجاه يعني هذا الاتجاه الصحيح للستوما. Again this is ممكن هذا نفس اللي شفناه أول بس الصورة مقلوبة. Again اللي وجدتكم إياه كله من مرضانا هذا من الليتريتشر. هذا لوب كولوستومي. هاي بتشوفوا الفتحتين والبوستيرير وول انتاكت. هذه أنا ليش حطيت الصورة جبتها من الليتريتشر مشان أورجيكم هاي حقيقة لأنه إحنا بنعملوش بس ممكن تقرأوا بسموه دبل بارل. الدبل بارل إنه إحنا we cut it completely فبصير عندنا two separate ends بس بنخليهم جنب بعض. هلا شو الدبل بارل إذا بتتذكروا أو شفتوا أفلام الكاوبوي القديمة في بعض البنادق بكون لها فتحتين اسمها دبل بارل. فهي شو بتختلف عن اللوب إنه اللوب البوستيرير وول ضل انتاكت هون مفتوح بالكامل. ما لها أي أدفانتج عشان هيك we don't use it عشان هيك ما عنديش مريض فجبت صورة من الليتريتشر. You can do it through laparoscopic surgery as you see in this one. This is an end colostomy. بس new يعني هذا immediately in the post-operative period لساته edematous ما أخذ يعني الشكل الصحيح. What are the problems associated with stoma؟ لو بدنا نسألكم لا سمح الله تخيل إنه you are having a stoma. What are the problems that you may get؟ ساعدوني أنا تعبت بالحكي يعني.
infection at the site يعني
الانفكشن this is to the outside يعني إذا ممكن يصير شوية infection بالسكن. It is not a known problem.
ممكن هيرنيا دكتور.
هيرنيا.
و electrolyte disturbance كمان.
dermatitis دكتور.
dermatitis, electrolyte disturbances.
stone formation أو ischemia, necrosis,
ischemia,
prolapse.
prolapse.
ممكن hemorrhage.
ممكن يصير bleed.
Contraction.
Yes. Impaction. You
ممكن
forgot.
fistula.
Not really. يعني احنا بنحكي على شيء extreme. يعني انا بسأل على complications بالstraight forward things. You have forgotten the most common problem. Depression, anxiety, its effect on the lifestyle. قد تستغربوا كثير مرضى كانسر they are not concerned about the cancer and its surgery as much as they are concerned about the stoma. And you have to remember that stoma is not done in the classical person اللي انتم بتتخيلوه انه والله شخص عمره 80 سنة وعنده كانسر وكذا. You may have it in the pediatric age group. You may have it in the young age group. Imagine a young female 20 with a stoma. فدائما بيجي السؤال يا دكتور does it affect the life of the patient? Does it affect the education, exercises, swimming, getting pregnant, sexual life, socializing? The answer, it will do so if it is poorly constructed. حتى تعرفوا شو أهمية الكونستراكشن وليش بتلاحظوا أنا خلال حديثي كنت دائما أقول لكم look at it, how does it look like, how does the skin look like. Imagine a person all through he's having stool leaking on the clothes. Their social life is off. On the contrary, if the stoma is well constructed, you will be surprised that they will attain a normal life. They will do their exercises, they can swim even, they can have their sexual life, they can meet with others, etc. In the early phase, they may need some support, some psychological support. In the West, ممكن تستغرب وتكون ماشي في الشارع تلاقي في قارمة مكتوب عليها stoma club. People who are having stomas, they meet there. هاي بتفيد الناس الجداد اللي صار عندهم ستوما جديد بيكونوا depressed they think that's the end of their life بروحوا بيجدوا انه هاي في ناس موجودين بيضحكوا بتزوجوا خلفوا بيلعبوا رياضة الى اخره فit help them to go over the stoma psychological impact. Fluid and electrolyte disturbances. أو بالمناسبة يعني على الموضوع هلا في عنا مريض already he's having a new stoma done he's youngish 24 جبنا له psychiatrists and they are helping him at the moment we have it. Electrolyte, fluid and acid-base disturbances. كل ما كانت الستوما proximal أكثر كل ما كان البروبلم هاي أكثر so we see it more with aliostomies. طبعا إذا jejunostomy it is catastrophic. That's why I said we like to do it as distal as possible. If it is an aliostomy and you can do it in the area of the terminal ileum, do it. At the start, the patient will have big amount of fluids and electrolytes. With time, there is some adaptation. And in a fragile patient, it may put them in renal failure, etc. At the moment, in Ward 10, we have an elderly patient, not that elderly, in the 60s, with a deranged kidney function. It's an acute insult, it will reverse with fluids and electrolytes because of an overproduction of the aliostomy. That's why in this regard, they need an advice about the diet. And well-trained dietitians and enthusiastic stoma nurses are informed about this, and they can educate the patient about what to do. And as I said many times, they need admission and resuscitation. Hernia. Look at this hernia. This is an end colostomy, and you can see the parastomal hernia. The hernia here can have all the complications of hernias anywhere: obstruction of the bowel, strangulation of the bowel. But you have a special problem here, because as you know, in hernia repair, many times we use mesh. Mesh is a foreign body, more liable for infection. The presence of the stoma will make the mesh much more liable for infection, and this creates a problem in the repair. That's why you should do your best, utmost best, to avoid the formation of parastomal hernia. However, the more the patient lives, the higher is the chance of developing parastomal hernia as the patient goes with age. And look at this, one of our patients. Look at this huge parastomal hernia in this end colostomy. And when I asked him, how comes did it reach this size? He admitted that he did not attain the post-operative follow-up for the last 10 years. And you can imagine what sort of problem we will have in repairing this hernia. Actually, the abdomen may not accommodate all the contents of the hernia back. Again, another patient with a parastomal hernia. This is what we mean by skin problems when the stoma is not created well. It is not, as you see, it's not delivered outside the skin. Forget about these. These are other things in the wound. This is a mucus fistula, which is the distal rectal end or distal sigmoid delivered to the outside. And this is a closer view. So you can imagine what sort of life this patient is having. The stool leakage is always there, and definitely the patient's life is ruined here. Luckily, we managed to reverse this hernia, and the patient is off this. This is a skin reaction, but this is not caused by the construction of the stoma. The construction of the stoma is excellent. It's either an allergic reaction or the patient is not taking care of it in the right way. Because if you don't apply the base well, or the one system well from the start, and you start developing skin reactions, then you will enter a vicious circle, because this reaction will increase more, and you will find a problem in putting the stoma on, and the circle goes on. Another problem with stomas is necrosis, and this is caused by the cut or no enough blood supply. We received this patient from another hospital. We managed him for 2 months, and it ended in death, not because of the stoma, but because of the original problem. So as you see, it is dusky. This is prolapse. And this is from the literature. And you can see that this is different from the pouching that we create deliberately to control the contents. Of course, it can reach bigger sizes. This is the same previous patient. This is from the literature, showing some of the complications. One of them is a prolapse. One of them is necrosis. One of them is the skin reaction. And this one is called retraction. So as you see, it is retracted inside the abdominal wall. And this creates a problem in applying the base and in avoiding the leakage of the contents. If this is an ileostomy, it's going to be a hell of a life. And now the companies have developed certain devices that can be put like a funnel in order to go around the problem of retraction, but many times it is a real problem and there is a problem in applying the base.
دكتور هاي ما بتتعدل يعني؟
If you want to reverse, it's going to be the same, the major surgery. You will open the abdomen and recreate the stoma. يعني, it's not a simple fashioning. لا. It's going to be a major surgery. The prolapse, you may be able to deal with it locally, may. Another problem is obstruction. And obstruction can be in a hernia or adhesions around the stoma, like any adhesions anywhere in the abdomen which has been violated by surgery. Look at the dilated bowel proximal to the stoma. So we go back to where we started. We said that stomas are created when you cannot resect, or you cannot anastomose, or you need to do it in more than one operation, or you want to protect the anastomosis, or when the continence is jeopardized. Now, what is the pathology that will need the stoma? Any pathology in the small and large bowel can create a situation where a stoma is needed. And if you go back to your pathology box, in the first chapter, they will put a table of the pathologies of the body. I hope you remember this. They will say congenital, inflammatory, the inflammatory specific, non-specific, bacterial, viral, fungal. Then they will say tumors, benign, malignant, primary, secondary, then vascular, then trauma, sharp, blunt, bullet, knife, then metabolic diseases, وفي الأخير ممكن يحطوا others يعني for the uncategorized. This apply to the indications for stoma. So I cannot put all the indications. لو بدينا congenital, you will find imperforate anus, hairsprung disease. إذا بدنا نيجي على الانفلامatory, you will find that there are infectious diseases and inflammatory bowel diseases. When it comes to tumors, colorectal cancer and small intestinal cancer, vascular, mesenteric ischemia, trauma, bullet injury, stab wounds to the small intestine and colon. So all the list of the pathologies, you will find diseases in the small and large bowel that will need a stoma. Examples. So I will only show some of the examples to make the picture clearer, and you can build up on that. ولو كان معي وقت كان ممكن مديت القائمة أكثر. This is a patient with trauma, not to the abdomen, to the perineum. This is the opening of the anus, and the sphincter is part of it. Of course, such injuries are common in wars because these are mine injuries and blasts. بكون ماشي, the mine will blow up, so it will blow the perineum. So part of the management of this patient was a stoma, and after the end of the treatment, the journey, this is the same patient after everything was repaired, and at one stage at the start it included a stoma. And in this case, the stoma was a temporary loop colostomy. temporary لأنه مخطط أسكره. كولوستومي دائما إذا عندك أنت مجال تعمل كولوستومي أو أليوستومي بتعمل كولوستومي لأنه the metabolic complications and skin complications are less. ولوب لأنه البول ما في أي شيء فإحنا طلعنا لوب وعودنا سكرنا. زي ما حكيت لكم لوب أو end، كولوستومي أو أليوستومي، permanent أو temporary، راح يعتمد زي ما حكينا على الباثولوجي، على السايت، على الانديكيشن of the surgery والcircumstances. In this patient, we had the pleasure to do the best, which is a temporary loop colostomy. Incontinence is an indication for a stoma, because dealing with a stoma, living with a stoma is much more comfortable than having incontinence. So you may do it merely because the patient is having incontinence which is not amenable for treatment. يعني واحد عنده spinal cord injury مثلا صار عنده incontinence. Dealing with a stoma is much easier than incontinence. Diverticular disease. Part of the complications of diverticular disease is diverticulitis. The severe form of diverticulitis will involve severe inflammatory process, sometimes pus, abscess, or even generalized peritonitis. In severe cases, you may not be able to resect because you may endanger some organs. In some cases, you can resect the inflamed part, but because of the presence of pus or stool in the abdomen, you cannot anastomose because most likely the anastomosis will disrupt. So you stage the operation. أنا بحكيش كل عمليات الدايفرتيكولار، أنا بحكي in some acute severe diverticulitis. So diverticular disease. This is one of our patients with diverticular disease, and look at this abscess and this sinus here. Severe inflammatory process. Even after we drain the abscess, the area is so inflamed. We managed to resect, but it was not safe to anastomose. And this is a closer view. So diverticular disease in certain situations may need a stoma. And this diagram shows that in diverticulitis, this is the diseased sigmoid colon. You resect it. If the situation allows anastomosis, you do it. If not, you will do this operation, which we call Hartmann's operation. Hartmann اسم شخص يعني. بعد ما عملنا resection هون, the proximal will come out as a temporary end colostomy, and this one will be closed, اللي هي rectal stump. على أمل إنه later on we will come and re-anastomose. مرات لما بتكون الديستال بارت طويلة تسهيلا للعملية الثانية مش بنسكرها، بنطلعها لحالها، بنسميها ميوكس فيستولا. زي المريض اللي ورجيناكم صورته اللي في عنده سيفير سكين رياكشن، قلت لكم هاي ميوكس فيستولا اللي تحت. So end colostomy mucus fistula. Any condition that leads to peritonitis like this and needs resection of the bowel, it's not safe to do anastomosis. So the patient will have a temporary stoma. سواء كانت هاي البريتونايتس من diverticular disease ولا من cancer ولا من vascular insults, whatever it is. It is not safe to do anastomosis in the presence of pus or feces in the peritoneal cavity. Of course, the details are left to the surgeon. Tumors may need stoma, especially if they are obstructed, and again, re-anastomosis in an obstructed colon is not safe. So many times we need to do a stoma if the cancer is obstructed, if the cancer is perforated, or if the cancer is in the lower rectum, that it includes removal of the anal canal. How can we decrease the stoma in obstructed cancer? If you can stent the patient, if you can put a stent here, then you can relieve the obstruction and make the surgery without stoma. These are obstructed tumors. So distal cancers in the rectum, if you can save the anal canal, you resect and anastomose. But by the way, many times this will need a temporary ileostomy because this anastomosis is very critical. Sometimes it includes removal of the anal canal, so the patient will have a permanent end colostomy. Sigmoid volvulus may be an indication for stoma because you are dealing with an obstructed, dilated colon, so the anastomosis is not safe. How can we decrease the use of stoma in volvulus? We try to deflate it by colonoscopy or sigmoidoscopy, and then do the surgery after 2, 3, 4 days with a prepared colon. But sometimes the endoscopy fails or the volvulus is already causing a gangrene in the bowel. This is a sigmoid volvulus. Even the pseudo-obstruction, which is functional, there is no organic disease, usually we deflate it by colonoscopy. However, in rare occasions, a stoma may be needed. This is rare, بس أنا بحطت لكم إياه مشان أقول لكم even the non-organic obstruction. may need it. Vascular mesenteric ischemia, as you see, and look at the gas in the bowel wall in the pre-perforation state. You may need to do a stoma, especially if you are going to do resection and you are not sure about the viability of the ends of the bowel. Inflammatory bowel diseases, they may need stomas if they present with toxic megacolon, for example. Look at this colon. Another example. 1 month ago, we did a surgery for toxic megacolon in a patient with ulcerative colitis. With a tumor, he was having both. We were obliged to put a stoma for him. And sometimes the inflammatory bowel diseases will cause a stricture and obstruction that is not responding to medical treatment. They may need a stoma. Sometimes the Crohn's disease involves the anal canal and the rectum severely to the degree that you need to remove that. So there may be an indication. How can we decrease the use of stoma in inflammatory bowel disease? Proper control of the disease medically, and now we have excellent drugs for that, and to anticipate the patients who will need surgery and do them before they come with an acute insult. In the past, ulcerative colitis was treated by total proctocolectomy and permanent ileostomy, like this one. Nowadays, we create pouches of the small intestine and we leave the anal canal and we hook them together so we avoid the permanent stoma. We may need to do a temporary stoma. So as you see, as we progress in medicine with drugs, with surgical techniques, we try to decrease the use of stomas as much as possible. I believe I have finished. As I said, I did not have enough time to bring about all the examples, but you can build up on the same philosophy. Remember the list of pathologies and remember what can go wrong in the small and large bowel in that list. And in the extreme cases and complications, they may need a stoma. So this includes the congenital. So you may need to do stomas in imperforate anus and hair-sprung disease. Inflammations like inflammatory bowel disease and diverticulitis, if you want to consider it as inflammatory. Tumors, stab wounds, bullets, etc. Mesenteric ischemia. So all the pathologies on their extreme of acute presentation, they may need stoma. What stoma you will do? Ileostomy versus colostomy, loop versus end, temporary versus permanent, right iliac fossa, left iliac fossa, will depend on what is the pathology, where is the pathology, what is the indication for the stoma formation in that particular patient. I hope I have conveyed the message, and if there is any question.
دكتور يعطيك ألف عافية.
الله يعافيك. بس هذا ما بلكي هذا الفيديو يمكن دقيقتين، هو من الإنترنت يعني، بس مشان
مش مشكلة مش مشكلة.
الصوت واصلكم؟
لا دكتور.
دكتور عفوا بس الفيديو
إذا مش واصل الصوت معناته ما استفدناش. على كل حال هاي so many errors the thing that we lack in our practices, and she discusses the issue with the patient before surgery and after surgery. She describes how to care with the stoma.
دكتور إذا بتحب تبعت لي الفيديو أو لينك الفيديو إذا كان هو على اليوتيوب على الواتساب، وأنا ببعتهم للجروبات.
مش حرزان يعني، لو انتم دخلتوا انتم نفسكم بتلاقوا غيره يعني. انا على عجل بجوز يكون في غيره احسن منه، بس
خلص.
المسجز منه انه there are stoma nurses and they sit with the patient. بكل اسف هذا احنا عمالنا بنعمله احنا كاطباء. هي عم تشرح له يعني كيف بدها تفتح الفتحة المناسبة بما يتناسب مع حجم الاستوما. how this is applied. احنا المريض بيتعلم عليه بعد العملية، بكون عنده الوند والابدومين is painful، فبيبدأ يتعلم على الاستوما بتندر ابدومين. كل أسف هي عم تشرح لها 1 بيس باج و2 بيس اللي لها بيز واللي ما لهاش بيز. هاي على 2 بيس.
دكتور إذا أنت فاتح الفيديو هو مش مبين عنا، مش مبين غير السلايدات سو فار.
الفيديو نفسه مش مبين.
مش مبين.
طب
يمكن
ما ليش ما
الشير.
حكيت من اول اذا ما عم بحكي لحالي انا؟
لا ما نحن بنتبه معك بالصوت.
ما استفدناش. خلص انسوا الموضوع. طيب any question؟ مش معقول يعني ما فيش question. والحضور 25 والشخص من خارج المجموعة. any